Hi everyone, this is me Dr. Atitipari once again, and today I have come with very important topic in psychiatry, and that is schizophrenia spectrum disorder. In this presentation we'll be learning about brief psychotic disorder, schizophreniform disorder, schizophrenia, schizoaffective disorder, and schizotypal personality disorder. But we'll obviously start with schizophrenia. So in any examinations, be it USMLE, PLAB, or NCLEX, and even if you are in the medical school or in a nursing school at the moment, this is very important topic in psychiatry. So you'll definitely see some questions from this topic, and this is easy topic compared to any other topic in psychiatry. But yes, I want you to feel much more comfortable with this topic so that you can deal with any questions in examination. So let's proceed. So schizophrenia spectrum disorder, in this firstly we'll deal with schizophrenia. Okay, so whenever you say schizophrenia, the person will have some positive symptoms, some negative symptoms, may have some positive symptoms, some negative symptoms, and obviously there are some cognition related symptoms. Okay, so let's begin. Schizophrenia is a chronic illness causing profound functional impairment. So symptoms category include positive symptoms. In positive symptoms, it can be excessive or distorted functioning, example hallucination, delusion, unusual thought processes, disorganized speech, bizarre behavior. In negative symptoms, it can have a blunted affect, apathy, anhedonia, allergia, asocial behavior. In cognitive, we see that the person may have reduced ability to understand or make plans, diminished working memory, and inattention. Till now, we all knew what is schizophrenia, that it is a chronic illness in which there is significant functional impairment. We knew some of the symptoms of schizophrenia, but to diagnose a schizophrenia, there are few conditions needs to be met. Okay, so there are 5 symptoms that we must know. One is delusion, next is hallucinations, which is often auditory hallucinations. So I'll be saying auditory hallucinations. So delusion, auditory hallucination, disorganized speech, catatonic or disorganized behavior, and negative symptoms. So out of these 5, if the person must have 1 out of 3, first 3. Okay, so if a person has either delusion or auditory hallucination or disorganized speech, either one of them or all 3 of them or 2 out of 3 of them, plus he or she may have catatonic or disorganized behavior or negative symptoms. So out of these 5 symptoms that we have learned here, the person must have 2 or more than 2 symptoms, but out of these, at least 1 symptom must be either delusion or auditory hallucination or disorganized speech. Then we say that the symptomatic criteria of schizophrenia has been met. And other condition is we have to meet timeline. Okay, so symptom onset must be greater than 6 months prior to the diagnosis. Onset must be 6 months greater than prior to the diagnosis, and requires greater than 1 month of active symptoms over the past 6 months. So when this criteria of time and the symptoms is met, then we say the person has schizophrenia. Now, why schizophrenia? Because there is altered dopaminergic activity, serotonergic activity, and dendritic branching in the brain. And when you see brain imaging, there ventriculomegaly is seen. Lifetime prevalence is about 1.5%. Males have a significantly higher risk than that of the females. In case of males, it's seen in late teens or in early 20s. So let's say in between 15 to 25. And in case of females, it's seen in late 20s and early 30s. Let's say 25 to 35. And the person who has schizophrenia has high suicidal risks. Heavy cannabis use in adolescence is associated with increased incidence and worsened course of psychotic, mood, and anxiety disorders. So again, the person who uses cannabis can develop heavy use of cannabis can lead to schizophrenia. Treatment is atypical antipsychotic, example risperidone or first line. Negative symptoms often persist even after the treatment despite resolution of positive symptoms. So even if the person's delusion, auditory hallucinations, disorganized speech, even if these things goes away, okay, but the blunted affect, anhedonia, allergia, if the person also have these negative symptoms, then these negative symptoms doesn't easily go away even with the start of antipsychotics. Now next slide is we'll talk about brief psychotic disorder. So if there are greater than 1 positive symptoms, okay, and that lasts between 1 day and 1 month, and then we say to, hey, the person has brief psychotic disorder and it is often stress related. So a person comes into the OPD clinic and he says that he has either hallucination, disorganized thought, and then auditory hallucinations, and he says that he had some stress in his life recently, and he said that but these symptoms haven't have been, let's say, it's only 25 days. Then we say that he or she may have brief psychotic disorder, not schizophrenia, because the time criteria is not fulfilled here. So we say he or she has brief psychotic disorder. Similarly, we have till now we have started about schizophrenia and brief psychotic disorder, and now we are dealing with schizophreniform disorder. If the criteria for the symptoms of schizophrenia is met, but for the time it's less than 6 months, then we say the person has schizophreniform disorder. Because remember, to say the schizophrenia diagnosis, to make the schizophrenia diagnosis, we need both symptoms as well as time criteria to be met, okay. But if only the symptoms criteria is met but not the time criteria, that means if the person has the symptoms for less than 6 months, then we say to the person has schizophreniform disorder. Next is schizoaffective disorder. In schizoaffective disorder, the person shares the symptoms with both schizophrenia and mood disorder, okay. To differentiate from the mood disorder with psychotic features, patient must have greater than 2 weeks of psychotic symptoms without a manic or depressive episode. So when we say schizoaffective disorder, the person has schizophrenia as well as mood disorder in him, okay, be it major depressive disorder or bipolar disorder, but he has both of them. But we also know that there is a condition where we say depression with psychotic features. So when we how to differentiate between schizoaffective disorder and depression with psychotic features. So when you say depression with psychotic features, the person always have depression and psychotic features together. But to say the person has schizoaffective disorder, the person must have psychotic features as well as this mood disorder, okay. Here let's say depression and psychotic symptoms, they must have these two criteria, but at some point over the time he must have only the psychotic features with no mood disorders for at least 2 weeks. Then we say it is schizoaffective disorder. So that's the difference, and you will often be tested for you will be given clinical scenario and you have to differentiate, choose one option, schizoaffective disorder or let's say depression with psychotic features. Then this is the line that is very important, okay. To differentiate from a mood disorder with psychotic features, patient must have greater than 2 weeks of psychotic symptoms without a manic or depressive episode. This is very important line. Next is delusion disorder. So if a person has greater than 1 delusion lasting for greater than 1 month, then we say it's delusion disorder, but without a mood disorder or other psychotic symptoms. There must not be any mood disorder or other psychotic symptoms, just pure delusion of 1 or more for lasting for greater than 1 month. Then we say he or she has delusional disorder. Daily functioning including socialization may be impacted by the pathological fixed belief but is otherwise unaffected and can be shared by individuals in close relationship. So if a husband has delusion disorder, over the period of the time even the wife may start developing that delusion, and that we call is polyalgiacs. Next is schizotypal personality disorder. Cluster A personality disorder that also falls on the schizophrenia spectrum may include brief psychotic episodes, example delusions, that are less frequent and severe than schizophrenia. So here we have learned about 5 conditions. One is schizophrenia. We learned about positive, negative and cognitive symptoms of schizophrenia. We learned about the brain imaging changes in schizophrenia and the treatment. Then we learned about brief psychotic disorder. Then we learned about schizophreniform disorder, schizoaffective disorder. We differentiated schizoaffective disorder with depression with psychotic features, and then we learned about delusional disorder and schizotypal personality disorder. Okay, with this we in the topic as such of schizophrenia spectrum disorder, but there are a few questions which are important for your examinations point of view. Let's go quickly for this. So a 22-year-old male presents with 8 months of auditory hallucinations, disorganized speech and a flight effect. Brain MRI shows enlarged large ventricle with neurotransmitter pathways mostly implicated in the positive symptoms of this condition. And so he meets the criteria of schizophrenia. So that's why we say is the person has increased dopamine in mesolimbic pathway. So option A is correct. Okay, so we say that there is increased dopaminergic activity in mesolimbic pathway for the positive symptoms. Next question is, a 28-year-old woman with a 7-month history of delusion, auditory hallucination, and social withdrawal is started on risperidone. After 4 weeks, her hallucination resolved, but she continues to show blunted affect and apathy. What is the most likely explanation? So answer is that although the positive symptoms is controlled, but still the negative symptoms like blunted affect and apathy is still there. So we say that negative symptoms persist despite treatment. So this is frequently the negative symptoms are very hard to get rid of. Okay, so atypical antipsychotics, example risperidone, are first line effective treatment for positive symptoms, negative symptoms, blunted affect, apathy, and inuria. Ataxia often persists even after the positive symptoms resolve. Do not increase the dose or switch medications based on persistent negative symptoms alone. Okay, these are very important lines for in real clinical practice. Next is USMLE step 3 questions. Schizophrenia. A 35-year-old man with schizophrenia is brought in by his wife, who has also begun to believe that the neighbors are government spies. So here we are dealing with something like delusion, in which the wife is now getting the delusion thoughts similar to that of the husband. The wife has no prior psychiatric history. What is the most appropriate next step? Answer must be separate the couple and treat the primary patient. Okay, explanation is this is a fully heterodox shared delusional disorder. The secondary individual here, wife, typically improves with separation from the primary patient. Only the primary patient requires antipsychotic treatment, not the wife. Diagnosing the wife with schizophrenia is incorrect without meeting the full DSM criteria. So here only the husband had some delusion and made the criteria of schizophrenia, was under treatment, but since the wife was with the husband for a long time, she also developed some delusional thoughts. So in this case, we don't treat the wife unless she also meets the DSM criteria for schizophrenia. So we just separate the wife from the husband and treat the husband with antipsychotics and everything, and we just counsel the wife. Next question is for NCLEX students. A nurse is caring for a client with schizophrenia who states the TB is sending me cigarette messages. With nursing response is most therapeutic? Answer is B. That is, I understand you believe that, but I don't see the TB sending messages. So rationale is the nurse will neither reinforce nor argue with delusions, acknowledging the client's experience while stating reality. Non-confrontational reality orientation is the most therapeutic response. Arguing or dismissing worsens trust. So you say, I understand you, I believe you, that you are feeling that you are receiving those messages, but I don't see the TB sending messages. So you, in one hand, you are with the patients, but also you want to give the reality check together. Okay, the main key thing is that you have to develop trust with the patient. And the next thing for the patient, next thing is a client with the schizophrenia is prescribed haloperidol. The nurse notes the client has a temperature of 39.8 degrees centigrade, muscle rigidity and altered consciousness, and diaphoresis. What is the priority nursing action? Answer must be recognize this as a neuroleptic mania syndrome and notify the provider immediately. So rationale is neuroleptic mania syndrome is a life-threatening emergency associated with antipsychotics, especially typical antipsychotic like haloperidol. Classical triads include hypothermia, muscle rigidity, altered mental status, autonomic instability. Immediate discontinuation of the drug and provider notification is priority. Okay, so with this I complete we read about schizophrenia spectrum disorder. We also deals with some of the typical USMLE questions as well as NCLEX questions. So I hope this slide was very important for you. Please go through this once really quick. You can increase the speed in YouTube to just go through this once, and then I hope you'll be able to solve almost all the questions from this topic. See you in next video. Bye bye.